We are very pleased to welcome you to the Omnicurus Originals Gynecology series. Today we have Dr. Rekha Rajendra Kumar with us. Dr. Rekha Rajendra Kumar is the present secretary of the Bangalore Society of Obstetrics and Gynecology. She is an infertility specialist in Bangalore and has an experience of 30 years backing her. She has received 6 awards and 3 felicitations, including 2 state awards as well. She has been a panelist in more than 300 national and international conferences. She has many papers and reports under her name, has done more than 50 radio and television talks. She is an active member of Karnataka Medical Council, Federation of Obstetrics and Gynecological Societies of India, Indian Association of Gynecological Endoscopists, Indian Society for Assisted Reproduction, and National Association for Reproductive and Child Health of India. She is also a very active doctor on Quora and regularly answers queries and problems shared by her patients, the fellow doctors, and general public. Welcome, Dr. Rekha. The stage is all yours. You may please begin.
Thank you all. Thank you, Omnicurus. Thank you, Vaishnavi, for giving me opportunity to talk on this stage, on this reputed platform. Thank you all the audience for sparing your time on me. I'm going to speak on endometriosis and infertility. What is the impact of endometriosis on infertility would be my talk for today. He who knows endometriosis knows gynecology. This is an age-old saying that is told by famous William Osler. This means a lot. Endometriosis is a benign, it's quite a benign, though it's very troubling and lurking, sitting there all the time, recurrent, in spite of all these bad factors, it is a benign condition which is estrogen dependent, progressive gynecological disease. If you don't attend to that, it silently progresses locally. Though benign, it progresses. So it's a progressive gynecological disease in women of reproductive age. And I underline my statement because here it gives maximum problem. Had the woman been postmenopausal or had the woman been not in the reproductive age bracket, it would have been a different issue because here we have to challenge the endometriosis versus reproduction. So it is the problem of especially reproductive age group people, and that is extremely common in infertile women, unfortunately. Yet, there is a much that is still not understood. We are kept in dark at many corners regarding this endometriosis, and thus, because of this factor, it involves lot of controversies, needless to say. How does the endometriosis affect infertility? In my presentation, I'm going to talk only about the infertility aspect of endometriosis. I'm not going to cover other than that, in the sense the postmenopausal age group or any other problems of endometriosis is not covered here. So let me talk about infertility factors. So how does it cause problem? Why endometriosis leads to infertility? One, it is a mechanical effect. The mechanical itself, in the sense the tubes get distorted, the ovary and the tube anatomy is distorted, the ovary and the tube proximity is gone. The tubal damage also, the tube per se, other than the anatomy between the ovary and the tube, that is picking up or the sucking up of the egg from the ovary, once the ovulation has happened, sucking into the tubal lumina is one factor. Other than that, the tube itself is damaged. What happens inside the tube? Because of the chronic blood accumulation, it is there is problem like hydrosalpinx, there's a dilatation of the tube, also the hematosalpinx. Because of hydro and hematosalpinx, what happens is the tubal cilia, that is the endothelium of the tube, is totally damaged because the long-standing chronic abnormality, chronic pathology that causes the brushing, what we say as the brushing of the tubal cilia that happens towards the uterine cavity, towards the ostia, all this is altered. Because the ciliary movement inside the fallopian tube or the endothelium is altered, the egg capture and the travel of the egg and also the fertilization is affected. There is chronic inflammation. There is inflammation everywhere in the pelvis. The pouch of Douglas is also inflamed. Tubes, in endometrium, the ovary, all are under chronic inflammation. The endocrine abnormalities are also associated problems. The attenuated LH surge, we don't get that sudden LH peak so that you can predict ovulation. That is not there. Luteinized unruptured follicle. Follicles are unruptured and luteinized, and luteal phase defect. All these are the endocrinal abnormalities that is carried along in endometriosis. Other than these problems, because of the additions in the pouch of Douglas or the tender uterus, the adenomyosis, pouch of Douglas is full of the endometriotic deposits. The woman also feels the deep dyspareunia, so she is not sexually cooperative. This adds to the problem of infertility. There are other problems at the molecular level. The previous slide said about the additions and rest of the factors. Here I am going a bit deeper, that is the molecular mechanism. What does happen here? There is also immune dysfunction in endometriosis. The antibodies are produced in the woman's body, unfortunately, act against her own endometrial tissue. So this is the anti-endometrial antibody causing what is something called as an autoimmune reaction. Because of this, her endometrium is not very conducive, not very fertile, does not accept the embryo, etc. There is increased polyclonal B activity, T cell, natural killer cells, monocyte activation, and whatnot. Local hostile environment. The environment is very hostile, and the peritoneal fluid is also abnormal. Because of this, the sperms which have migrated into the peritoneal fluid, either when there is a natural coitus or when you have done IUI, the sperms which have migrated into the peritoneal fluid are also not received in a very warm, they do not get any warm atmosphere. The atmosphere is not conducive to them because of the presence of the prostanoids, cytokines, and so many other immune reactions that happen there. The peritoneal fluid, abnormal macrophages are there, and the cytokines. Ultimately, there is immune dysfunction is so much, and it is everywhere. Now, another thing that is ROS, reactive oxidative species and free radicals. This is another thing other than the immune reaction that happens at the molecular level. What does happen here? Listen to me. Iron that is sequestrated by the macrophages as ferritin. There is a lot of iron because there is a lot of blood that is trapped there. So that this iron causes problems in the macrophages. They are loaded with the iron. Thus, macrophages are overloaded with iron, and during its attempt to destroy the iron, the body cells want to destroy this extra burden of the iron. During this process, they produce lot of reactive oxidative species. And all of you know that reactive oxidative species is not good for the body because they result in lot of free radicals. So what does this ROS do? The additions are formed, which I have already told. The tubo-ovarian anatomy is distorted, etc. There is impaired tubal motility. We want a proper physiological fallopian tubal movement, which does not happen. Because of that, the egg pickup, when there is a natural coitus and the ovulation that happens, they do not get pregnant. Spontaneous pregnancy is reduced because of this factor. There is a decreased ovarian volume, decreased viable eggs. We are not happy with these eggs because they are not healthy, good, viable eggs. There is toxicity to the sperm also. The ROS is toxic to the sperm plasma and acrosomal membrane. Thus, it affects the sperm motility, velocity, and the sperm cap, that is the acrosomal cap reaction is also not good. Because of this, the acrosomal cap cannot penetrate the zona pellucida of the egg, and thus the fertilization is also hampered. There is sperm phagocytosis and inability, this is what I was telling, inability to penetrate the oocyte. The zona pellucida is not penetrated because acrosomal reaction is not fine. There is arrested division of the fertilized egg. Even if there is fertilization of these eggs, the proper division does not happen. Formation of morula, blastocyst, it does not progress to that level in a healthy way. That results in failed fertilization and ultimately the demise of the embryo. What is the pathophysiology? And the impact of the endometriosis on IVF outcome because of all while whatever I told in my previous slides, like ROS, the molecular mechanism problems, the immunology problems, etc., ultimately because of all these things, the impact would be there is disorder of folliculogenesis. We do not get the good, proper, nice growing follicles. Next is fertilization. That does not happen. Endometrium is not fine, so implantation does not happen. So there is problem at each level, from ovarian steroidogenesis, the quality, fertilization, development, everything. There is poor ovarian reserve. There is abnormal and the slow follicular oocyte development. We stimulate the patient for the IVF, or even otherwise when there is if you're watching the spontaneous menstrual cycle that happens when we have not interfered, we see a follicle growing at the rate of around 2 to 3 millimeter per day most of the times, and that is quite physiological. But that does not happen here. It is abnormal, and also it's a slow growth of the follicles. There is a lower cytoplasmic mitochondrial content. The mitochondrium does not have, it's a powerhouse of energy, as all of us know, but that mitochondrium is not healthy. So ultimately the oocytes are defective. There is alteration in the structure as well as the function of this oocyte mitochondria. The spindle abnormalities in these oocytes, increased apoptosis of granulosa cells, low ovarian response. As I said, it does not grow. Expected growth is not there, and ultimately the growth hormone, the gonadotropin, what we need is much more. If we are using 150 here, even 300. They may not respond. The follicles are atretic. Ultimately, there is ovulation failure. So we get lesser number of follicles, and they are also not good. Number of fertilized oocytes and high quality embryos are not there. Our embryologist, when he says, "Madam, your blastocysts are quite good. Your day 3 embryos are quite good," that scene we do not get here. There is a decreased estrogen production, dysregulated endometrial function, lower implantation rate because the egg is defective, the embryo is defective, and the endometrium is also defective. Where do I get the good implantation here? So ultimately, all this result in low clinical pregnancy rate, and even if the woman has conceived, unfortunately may land in first trimester miscarriages. The cycle cancellation rate is so high that it is to the extent of 3 times compared to the normal woman in these women because of all the above problems which I have mentioned. Unfortunately, this woman needs more of growth hormone. Difficulty to conceive, even if you have conceived, may result in miscarriage. She had come to us with lot of hopes in this cycle, say till day 12, day 13, I have put her on so many drugs and gonadotropins. She would have spent so much on me. Ultimately, I have to tell her that your cycle is cancelled. Sorry. That's a very pathetic state for me. Endometriosis and infertility. This is just to concise. Don't think that I'm repeating the slides here. Just I want to highlight some facts that what I want to say here is minimal or mild endometriosis causes abnormality or results in infertility because of these factors. That is the molecular, immunological factors, etc. There is anovulation. I said LUF, LPD, corpus luteal insufficiency, all the factors. But in moderate and severe endometriosis, or what you call is the 3rd and 4th stage of endometriosis, the above factors are there, and they are compounded by other factors which I have mentioned here, like the anatomical distortion. In mild and moderate, they do not have the anatomical distortion. There is, of course, the endocrine abnormalities, subtle problems, and minute problems, agreed. But other than that, they do have the extra problems like the anatomical distortion. There is lot of addition. We call as the worst form of this, what we call as a frozen pelvis. The endoscopists are very scared of this. It's a nightmare. Certain kind of situations do happen when we put a scope and see inside the pelvis is plastered or frozen, other than the above mentioned problem. This is the worst scenario, what I explained. Anyway, a systematic review of 27 studies, that was an ample study, has concluded that the presence of stage 3 or 4 endometriosis, 3rd and 4th grade, reduces the implantation and the clinical pregnancy rate to a very great extent, that is to extent of about 40%, and that's quite huge as compared to normal women. Coming to bit of statistics, Prevalence of endometriosis, 1 in 10 suffer from endometriosis. I did not believe this when I went through the studies when I was preparing for this talk, but it is quite unfortunate and it is true also. It may be subtle, small, invisible, subclinical endometriosis, but 1 in 10 women suffer from endometriosis. 25 to 50% of the infertile women have endometriosis. Among the infertility population, it is to every second or third, fourth woman. The reverse fact is also true in the sense 30 to 50% of the women with endometriosis are infertile. So the vice versa is also the same statistics. Infertile women are 6 to 8 times more likely to have endometriosis than fertile women. That's quite huge and quite scary. The frequency of endometriosis among women with infertility subjected to diagnostic hysterolaparoscopy, we do not do in all the patients. Let me explain in my future slides. Anyway, if you have done that, you would be surprised to know that it is about to the extent of 48%. The result of IVF in advanced endometriosis is 36%, almost 40% reduced, and the light at the end of the tunnel is about 25% of them do conceive after you have done some kind of reparative or the restorative surgery in endometriosis. I will enlighten upon this in my future slides. Now, the treatment of fertility or the treatment of the infertile woman depends on all the factors which I have mentioned here. Her age is very, very important, as all of us know, because as the age advances, the fertility quotient also reduces. If she obstetric status, if she already has a child, I'm quite happy. I can be a bit relaxed about the second child. The previous ovarian surgery, I don't know how much of that has hampered her fertility. Was it a big endometrioma or was it a tossed ovary? Has it really taken her chunk of the ovarian tissue? And effect of the medical therapy. Has she come to me taking all the treatment? So many things. The stage of the disease, the ovarian reserve, even if she has not undergone any previous surgery, what is the ovarian reserve? Even if she is a fresh case to me, if her AMH is less than 0.5, I'm not happy. And other factors, of course, will compound this issue. Not only the endometriosis, if there is a tubal factor like a huge hydrosalpinx, or if the male factor is not fine, I'm in a bad situation regarding this case. The medical management can be given in all these three situations. Sometimes we just treat it as a first line treatment, even if she's a case of endometriosis, diagnosed, undiagnosed, symptomatic, asymptomatic. She's come with history of infertility, is eager to conceive, and I just give her the medical treatment. I might not even be knowing that she has some endometriosis if there are some powder spots or gunshot type of deposits. After surgery, it is medical treatment we do give to reduce the recurrence. I will talk about that in my future slides. And sometimes before the ART and even during the ART, we do give medical management. No single optional treatment for endometriosis, that is for sure. Medical management of endometriosis is indicated in where do I opt for medical management. Young women with a shorter duration, say around 2 years or lesser than 2 years of married life, effective married life rather, early endometriosis, that is 1 or 2, not crossed the second stage of endometriosis, and without much anatomical distortion. I underline my statement. There should be no anatomical distortion. The tube and ovary relation should be quite healthy and should be well maintained, because otherwise it is quite difficult for me to treat her and I have to take her for IVF. They should be offered the controlled ovarian hyperstimulation with IUI without surgery. Endometrioma less than 5 centimeter are also the candidates for medical management. Regarding this statement, there is lot of confusion and lot of factors which tell, in the sense some people do say it is 3 centimeter, some say 4, but some say 5. So it's always between 3 to 5 centimeter. Lot of studies and lot of confusion about this number. Those which do not come in the way of ovum pickup. Sometimes they do get the endometrioma and it is 5 centimeter, but it does not come in the way of egg pickup. And my eggs are growing quite fine. So I may be able to do my pickup without endometrioma coming in my way. And those infertile women with poor ovarian reserve, because ovarian reserve is already poor, either because of just like that, or they're elderly, or the advanced disease. These are again the women who cannot be targeted for the surgery, because if they are subjected to surgery, I may reduce their reserve further, because whatever kind of surgery I'm going to do, I'm going to touch the ovary, and for sure the reserve is going to go down. And the last is the recurrent endometrioma. These are the ones where we have done medical treatment or the surgical treatment, and they've come back to us with the same problem, that is the endometrioma, and already her reserve has come down. And endometrioma is such a disease, as all of you know, that it is known for its recurrence. So these are recurrent endometrioma is not so uncommon for us to see. So these are the women, again, I would like to opt for medical management. Medical management for pain by suppression of ovulation with oral contraceptives or the long-standing progesterone like DMPA or even oral medroxyprogesterone for months together cannot be used here when I'm thinking of fertility treatment patients, when I'm treating the fertility problems. They can be addressed to those kind of women who are no longer wishing for pregnancy. It's out of the fertility bracket. Medical management for infertility includes the ovulation induction, controlled ovarian hyperstimulation, plus or minus IUI and IVF. Aromatase inhibitors and gonadotropin, that is GnRH analogs, that is the agonist, may be given before and after the surgical treatment. So they have the role both pre and post-surgical phase. Coming to IUI. Women with endometriosis definitely have to be referred to ART earlier because their fertility is already hampered. Endometriosis has decreased per cycle conception rate in comparison with male factor and unexplained infertility. What I want to say here is, if the woman had associated problems like male infertility or it's an unexplained infertility, and if she did not have endometriosis, she would have been in a better situation than having endometriosis. COH and IUI should be considered within 6 months following the surgery. This is very important. I reiterate on this statement. In the treatment of subfertile women with AFS or ASR, American Society of Reproductive Medicine, stage 1 and 2 endometriosis, when at least one tube is patent instead of expectant management. What I want to say is, after the surgery, within 6 months, you have to take her into the wings of IUI. Don't tell her, sit at home, I have cured your problems, I have burnt your small endometriotic spots, you are quite fine, I have released your adhesion, sit at home. No, I have to tell her that within 6 months of surgery, you have to be subjected to IUI, because the success rate of this, that is IUI, is much more according to American Fertility Society or American Society of Reproductive Medicine, and that we have exactly seen many times even in our practice. In minimal and mild endometriosis, superovulation with IUI, that is about 3 to 4 cycles, have given us the result of 10 to 15% per cycle, unlike waiting and sitting at home for the spontaneous pregnancy to happen. Repetitive superovulation with IUI cycles have a plateau effect. Maximum I can try for about 3 months, maximum to 6 cycles. After that, it just drops. So 3 to 6 cycles of IUI with controlled ovarian hyperstimulation soon after the surgery. If she does not conceive with this treatment of IUI at the end of 6 cycles, please counsel her, please counsel the couple to go ahead for IVF. Controlled ovarian hyperstimulation IUI, some statistics here. Higher live birth rate with COH and IUI is about 15% compared to no such treatment. That is a expectant management. Clomiphene rate and IUI triples the mean fertility rate to 9.5%. Letrozole has given similar results, but FSH or HMG, that is use of gonadotropins, increases the success rate to 15%, unlike it is 9.5% of oral ovulogens. In stage 4 and 3rd and 4, of course, as all of us know, that it is 50% of that. Endometriosis reduces per cycle conception by half. Now, which are the patients? Who are those women whom I am going to counsel for IVF ICSI? Diminished ovarian reserve, as I have already told, poor ovarian reserve women, already 3 cycles, maximum 6 cycles of IUI. I have already tried and honestly done that in a very proper way. Presence of adenomyosis other than endometriosis, female age more than 35, otherwise also their ovarian reserve is going to fall by 35 years. Recurrent endometrioma, presence of other factors, bilateral endometrioma. I'm not happy here because both ovaries are affected, and of course her AMH is going to go down, and what I'm going to do sitting with my IUI there. Infertility duration more than 5 years. They have tried all kind of treatment or no, but she has been infertile for past 5 years and been trying. Stage 3 or 4 disease, that is the advanced stage of endometriosis. These are the women where I should directly take her for IVF ICSI. Example, recurrent endometrioma or her age more than 35 with endometriosis. Don't tell her for IUI. Take her directly for IVF. Okay, now I have already told it's IVFs in certain cases. Is it IVF or ICSI? Am I splitting between the two? Which is better? What should I go for? Bernhardt et al. In 2000 itself has reported that IVF is not for those women, those patients who are suffering from endometriosis, especially those who are suffering from stage 3 or stage 4, should go for ICSI, because we have to give them higher level of treatment. What happens here? What happens in IVF? We are banking on the sperm movement, capacitation of the sperm, positive progressive motion of the sperm, etc. And that is definitely hampered. So we want these women to go for ICSI because the basic yield itself is low. We have very few eggs in hand, and ultimately we have when those who are okay for ICSI itself have reduced. So ultimately I have only a handful of eggs and I have to give her the best treatment possible. Now I have told about the medical treatment. Let me talk on surgical treatment. Which are the women, who are the women where I should tell them that you have to you have to be subjected to surgery. Pain which is attributable to endometrioma, or she has any other symptoms like, as I have told, deep dyspareunia. Potential for rupture. It's such a big, it's 3 to 5 centimeter. It is about to rupture. Inability to access these follicles during pickup. Size that is more than 4 centimeters. I have already told that as you go more deep, as you study more, as you read more of the literature, you get 3 centimeter, 4 and 5. So according to Donez, you bring it by 1 more centimeter down, and he says that it is more than 3 centimeters because it may give compression to the effect of follicles. It does not allow the follicle to expand, maybe purely because of the mechanical effect itself, and it interferes with the ovarian response during controlled ovarian hyperstimulation. Those which obscure the OPU, that is the ovum pickup, to improve the access to the follicles. Thus they avoid the technique. Thus we want to avoid these technical difficulties and to avoid the follicular fluid contamination also. Not only the mechanical factor, not only want to improve the access, improve my access to the follicles, also accidentally I may get my pickup needle tape getting contaminated by this follicular fluid. Sometimes I'm suspicious of the features in ultrasound. The usual typical feature on ultrasound is the ground glass appearance of the, as I have shown in my picture in the right hand up corner, it is the typical ground glass appearance. Sometimes I'm not happy. It is not like that. Some white shadows, some septations. It's a little bit different kind of appearance where I'm not so happy about my diagnosis, and I want the fluid and the tissue for the histopathology, and that will be the final decision maker for me. So these are the cases where I have to subject the woman to surgery. If there is concern of the occult malignancy, of course, don't postpone. We have to make a histological diagnosis, and that cannot be deferred. Associated with infection or ovarian abscess, endometriomas are known to catch infection, attract the bacteria compared to any other kind of lesions. DIE, that is deep infiltrating endometriosis. Any kind of endometriosis where the endometriotic spots are deeper, more than 5 millimeter, they are called as deep infiltrating endometriosis. Okay, coming to the surgery, I have told the indication. Now let me tell you what kind of surgery I should do on her. Should I open her up or should I take her for laparoscopy? Yes, laparoscopy is the gold standard of diagnosis. I might have done an ultrasound, I might not have picked up, or even any other investigation, higher end like MRI, might not have picked up, or even if I have picked up, laparoscopy is the gold standard because I'm going to see with my eyes. I might not have taken the specimen for histopathology, but seeing with my eyes makes me sure where the small spots or the small superficial endometriosis is there. And I can even stage the endometriosis there. If I want, I can take a biopsy. First line of treatment is excise or destroy the lesion. Destroy this endometriosis because it is enemy of fertility. Any endometriotic implant seen during laparoscopy is taken care of. You have put a scope. This is for though you have intended in the beginning to diagnose the endometriosis or stage endometriosis, but if you have seen that there are some powder spots or the gunshot, whatever we call the peppers appearance, whatever, you have to destroy. Use your vaporization or even the bipolar and just destroy those endometriotic implants. Minimal or mild disease may benefit from surgical ablation. Cumulative pregnancy rate is around 43 to 60%, quite rewarding, isn't it? Following the laparoscopic surgery and IVF ICSI is about 30 to 40% per cycle live birth. Pregnancy chance reduces with severity of endometriosis, and that is common sense. Now, how and why should I counsel these women? Counsel because one, she should know what I'm doing for her, why she is spending money on her treatment. Her husband or the relatives or family members who are close to her, like her mother, should know what is happening to her and why we are subjecting her to surgery. Also, medico-legally, to save our own skin, we should counsel the woman. The woman should be counseled regarding the risk of the reduced ovarian function. I underline my statement. This is very, very important because after the surgery, invariably, her AMH is going to go down. Her ovarian function will not be as much as it was pre-surgery. Sometimes, to our surprise, when we put the scope inside and see one ovary may be completely involved with the endometrioma, and there may be hardly any normal ovarian tissue around that. So in those cases, practically one ovary is gone. The decision to proceed with the surgery should be considered carefully if the woman has had the previous ovarian surgery, because I don't know how much of the previous ovarian tissue is remaining. Again, what is her fertility quotient? So these are all the deciding factors before the surgery. Recurrence is quite common. We have to tell the patient, her husband or the close relatives that how much ever my surgery was fine, however good I have done my surgery, the recurrence can happen. It is known to happen. I have mentioned in the very beginning definition of endometriosis. I have told that recurrence is quite common in spite of thorough surgery. So proper counseling is necessary. She should not come back and ask us, doctor, you have done everything. You said everything is fine. Have removed everything. Then why did it come back? Have you left some amount of endometriotic tissue there? Was your surgery not fine? So I have to explain all this. Now, what are the advantages of laparoscopy? Why should I do laparoscopy? Prevents the endometriosis progression because I'm going to drain that endometriotic tissue or burn those spots in the pouch of Douglas, going to do this adhesiolysis. So it prevents the endometriosis progression. It reduces the inflammation in the pelvis because I have removed the endometriotic tissue as much as possible. So the local inflammation is reduced to a certain extent. There is decreased toxicity because there is inflammation reduced and the endometriosis tissue is taken out. So there is a decreased toxicity to the embryos and the gamete. It enhances the uterine receptivity also because, as I have told, the local inflammation or that immune reaction is reduced to a certain extent. After we've removed all that, we are given a thorough lavage, we are given a normal saline wash, etc. So we are going to make the whole pelvis more conducive and more friendly for pregnancy. Okay, is surgery fine always, or is there any negative impact of the surgery? more cautious surgical approach based on the evidence that less is more. The lesser you do, the lesser you handle the ovary is good. That is better. Are we causing more harm than benefit with surgical excision ablation? Not always. It depends upon the surgical expertise. It depends upon the stage of the disease. It depends upon how much of the addition is there. Also, how much of the ovarian tissue you are handling or removing the ovarian tissue. Absence of plane of cleavage. It does happen in advanced case of endometriosis, or if she is pre-treated with GnRH analog, it does happen. What? Absence of plane of cleavage. So healthy ovarian tissue is removed by stripping the cyst wall. All of us know it is a traction and counter traction is the tactic of removing this, that is stripping of the cyst wall. So recognizable ovarian tissue inadvertently excised together with the endometriotic cyst wall during stripping consisted of tissue which contained the primary all stages of follicles in around 70% of cases. The tissue which was taken for histopathology and examined under microscope, unfortunately in 70% of the cases, the stripped endometriotic tissue contained these precious primordial and primary secondary follicles, which we very much wanted inside her. The healthy ovarian tissue was found in 97% of the cyst specimen. Bigger the cyst, more the removal of the ovarian tissue, of course. Coagulation for hemostasis damages the blood supply. Yes, of course. We want hemostasis, so we are going to do some thermal coagulation. Though we are using bipolar, we are going to damage blood supply to a certain extent. Negative correlation between the stage of endometriosis and pregnancy rate. Higher the stage of endometriosis, lesser is the pregnancy rate. Surgery close to the ovarium hilum should be avoided because that is going to seriously hamper the blood supply to the ovary and thus the follicular development. Ablation and cystectomy. What is the advantage of ablation? What are all the things going to be happy about the ablation, and what are all the things that you are happy about the cystectomy? That is, when you do the ovarian ablation, the cyst wall is ablated, but you are not going to excise. The diathermy is more used. There is less bleeding, unlike cystectomy. A proportion of the follicles are destroyed, of course, because of the ablation, because of the thermal coagulation. The follicles, certain number of follicles are destroyed because of the thermal injury, but it is less compared to your stripping. Lesser loss of primordial follicles when it is ablated. But the disadvantage and very important factor is there is higher risk of recurrence because you have not removed the tissue in toto. You have not stripped the abnormal or the causative factor. When it comes to cystectomy, the internal cyst wall, that is the endometriotic cyst wall, is excised completely by stripping from the underlying stroma, as I said, because of traction and countertraction. Diathermy is less used because you are removing the tissue than you are keeping it there and ablating. A proportion of the follicles may get lost because the chunk of the stripped cyst wall has come out, which carries the follicles along with that. More loss of primordial follicles because of that. But the positive factor of this, though primordial follicles are taken out in a larger number, the advantage of cystectomy is there is a lower risk of recurrence because the important problem is removed. You have removed the whole of the endometriosis along with the cyst wall. Patients with the complete removal of the endometriotic cyst, that is the cystectomy, had spontaneous pregnancy rates of about 25%. That was a spontaneous pregnancy rate, and live birth rate of 19%. Surgical removal gave shorter time to pregnancy and live birth rate with IVF. Hence, in subfertile women, gold standard is laparoscopy and surgical eradication. First is laparoscopy, see what is there, diagnose whether she has endometriosis or not. If she has endometriosis, whatever best you can do, you do for her. Surgical eradication of the minimal and mild endometriosis has shown increased spontaneous, all the three stages, either spontaneous or intermediate, that is IUI or IVF ICSI birth rates. After surgical surgical ablation and fulguration in stage 1 and 2 with superovulation with gonadotrophins and IUI, it was 2 to 3 times higher live birth rate compared to just medical treatment. So this is ablation immediately followed by IUI. In patients who had IVF ICSI after laparoscopic surgery, around 50% conceived in stage 1 and 2 and around 28.3% conceived in 3rd and 4th stage. Bit of variation in my statistics, though overall it is same because all are taken from different papers. Conception rates were maximum in first 6 months and dropped after 1 year of surgery. Spontaneous conception was around 23.2% and abortion rate was around 15%, though they have conceived. AFS or ASRM says proper operative laparoscopy increases the pregnancy rate, and it is not just diagnostic scopy what you're supposed to do. That's what I was telling just few minutes back. Just don't put the scope and come out. Put the scope, check the ovaries, check behind the remote places like the ovarian fossa, pouch of Douglas, the anterior pouch. There may be endometriotic spots somewhere there. So you have to not only do the tubal patency test, check thoroughly if there is endometriosis, whatever stage, give a suitable treatment. Excision of the endometriotic capsule increases the spontaneous pregnancy rate compared to drainage and electrocoagulation of the cyst wall. Operative laparoscopy increases spontaneous pregnancy rate also. Presence of large endometriomas at the time of ovum pickup significantly reduce the number of oocytes retrieved compared to the healthy ovary. Maybe because the eggs have not grown, or because of the mechanical effect, or I'm not able to see them when during egg pickup, etc. Ovarian endometrioma reduces the rate of ovulation in contrast to normal ovaries, that is about half. So, small endometriomas, which I will put it as less than 3 centimeters with a short period of infertility. Medical management with STOH and IUI can be tried for 3 to 4 cycles before taking the patient up for laparoscopy. This is a sort of summary or the concised slide. Large endometrioma, which are more than 3 centimeters, long-standing infertility, laparoscopic cystectomy is the first line of choice, and immediately patient is put on GnRH analog for 3 to 6 months and then immediately taken for IVF ICSI. So these two statements, according to me, are quite useful and to be reiterated. So this has proved to be very successful. Should all endometriomas be excised before ART? Although surgical excision gives a satisfactory pregnancy rate, the concern about the removal and the ovarian reserve is there whenever you have excised it surgically. Lap cystectomy before COH IVF does not appear to improve the fertility. These are some little bit contradictory statements, but I thought we should watch or see or learn the endometriosis from all aspects. So little bit contradictory statements are also there. Lap cystectomy before COH and IVF does not appear to improve fertility according to few studies. Asymptomatic endometriomas may be better directly taken for IVF ICSI. This is one more. TVS aspiration, transvaginal aspiration of the endometriosis, that is endometrioma rather, before IVF ICSI offers a non-surgical approach. We are not happy with this, I'm not happy with this, and according to me, this is not a right way to practice. That is, the aspiration of endometriosis is only in a very few section of infertile endometriotic patients. It is not a blanket statement to all. In infertile women with endometriosis, when they have small endometriomas, there is no evidence that cystectomy prior to treatment with ART improves the pregnancy rate. In women with endometrioma which are larger, bigger ones, clinicians should consider cystectomy prior to ART to improve accessibility of follicles and so many other factors which I mentioned. So more than 4 centimeter, what are all the problems? I have been telling that problem during pickup, problem during pickup. What are these problems? Retrieval may be difficult because of the cyst itself. There is an added risk of cyst puncture. The needles are fresh, disposable, and very pointed ones are so sharp that it may rupture during the pickup, because when I see on my ultrasound screen, though I'm concentrating on the follicle, I might have gone through a huge endometrioma. Infection and the ovarian abscess are quite accompaniments of the endometrioma. Follicular fluid gets contaminated. This is not a happy situation for us. We immediately have to tell the embryologist and tell them or her that this is a contaminated follicular fluid. Please keep it away, keep it separate from my other eggs. You see those OCCs and even fertilize them in separate dish. Should all the endometriomas be treated before IVF ICSI cycles? According to human reproduction, that was a big question. Look at this. No difference in the implantation rate, pregnancy rate, and miscarriage rate if large endometrioma is excised according to ASRM guidelines, but I do not agree with this fact. There is lot of difference if large endometriomas are excised, drained, at least the mechanical effect is gone. The pressure on the other eggs is gone. Surgery is better avoided. I said laparoscopy all this while, but can I use the surgery for all the patients? Can I drain all the endometriomas? Can I do the cystectomy and stripping of the wall for all my patients? No, it is to be avoided in the following list. If the woman is older, she's 35 and she's expecting pregnancy, wants to get pregnant. Asymptomatic patients, they're quite normal. The endometrioma is small, around 3 centimeter or maybe even smaller. I don't want to take, especially if she's asymptomatic, I don't want to take her for surgery. If the woman is with low ovarian reserve, I'm the last person to subject her to the surgery until and unless I have a pressing situation like a large endometrioma. Bilateral endometrioma, both ovaries are hampered, but if the other follicles are coming up, if rest of the things are fine, let us wait for some time and not take her under knife immediately. Prior surgical treatment has been taken. She's been subjected to surgery earlier by some other surgeon, and now she has come to me with recurrence. So again, I will not subject her to surgery. The ovarian damage after surgery. Ovarian reserve after surgery is related to the size of the endometrioma because it is directly proportional. Surgery damages the ovary by removal of the healthy ovarian tissue and the vascular injury. The ovarian damage is both qualitative in the sense the AMH or the performance, the fertility performance also comes down, and quantitative, that is the AFC, antral follicle count number, is also reduced. So the AMH value is reduced after the surgery, needless to say. The outcome of the repeat surgery is worse, definitely yes, with further loss of the ovarian volume and antral follicle count. IVF ICSI cycles, post endometrioma excision, what happens? The reduced ovarian response on stimulation, quite expected. So the control ovarian hyperstimulation needs more. She needs more gonadotrophins. Number of days are increased. If other cases 9-10 days, if I'm getting good eggs, she may need 11-12 days of gonadotrophin, that too in higher doses. Reduced ovarian volume, antral follicle count, and even the oocyte yield is reduced. The estrogen level also is reduced. She is in a hypoestrogenic state kind. So this reflects on the endometrial growth. My endometrium is not coming up well. So the embryo transfer is getting difficult. The exogenous estrogen which I am supplementing needs to be given in a larger doses. 13% risk of severe ovarian damage is known after the surgery. So probably no effect on IVF fertilization, pregnancy rate, and subsequent ART outcome, surprisingly. This statement has been given in many of the studies and a bit surprising. What are the limitations of the surgery? High risk of recurrence. Real unfortunate thing. 25% at the end of 2 years, that's quite big number, and about 50% at the end of 5 years, and this number may increase if the surgery was not so judiciously done. About 40 to 80% of the women do get pain. They come back to us with the same dyspareunia or dyschezia, any kind of pain. Unable to reverse the inflammation, whatever inflammation is there, is difficult to reverse because it is at the molecular level. It influences the sperm and oocyte quality, fertilization, and implantation. Post-operative medication is required even if you have done surgery to reduce the recurrence. What are all the different kind of surgery that is needed? It varies. There is a big spectrum of the different kind of the surgery what we are supposed to do once we put our scope. It may be just a drainage, that's make a big opening and rinse and remove all this endometriotic chocolate material. The aspiration alone, as I have already told previously, that I do not recommend this. Incision and drainage, irrigation, little more than that is ablation, that is cauterize all the points, stop the bleeding, remove the active endometriotic tissue, vaporization, etc. The present one, that is incision, drainage and cystectomy, is the standard one which gives the least amount of recurrence. Destruction of the internal cyst wall with carbon dioxide laser or the bipolar diathermy is also done by few. Adhesiolysis, free mobilization of the ovary. They may be kissing ovaries in the pouch of Douglas, releasing those adhesions, clearing pouch of Douglas. Destruction of the peritoneal lesions. Some peritoneal spots might have appeared. After the surgery, the GnRH agonist for 3 to 6 months and second look laparoscopy. What my GnRH agonist has done to her. So I am curious to check again by second look laparoscopy, and if I find something there again, I don't want to do a big radical surgery. I just want to do a minimal surgery there, because my interest now is that to subject her to either IUI, IVF, whatever I decide on her, and make her pregnant as early as possible. So it is a minimum second look laparoscopy surgery. All the above have risk of incomplete surgery because we are in such a difficult situation. We want the endometriotic tissue to be removed, eradicated completely. At the same time, we do not want to hamper the ovarian problems. In the sense, the ovarian tissue we want to restore as much as possible. So, in the melee, the problem can happen that we are a bit defensive and might not have removed or done an extensive daring surgery, and because of this the recurrence may happen. Excision or the cystectomy is preferable because of less recurrence, already told, but excision results in more reduction of ovarian reserve. Now sometimes even before the surgery or after the surgery, I do give GnRH agonist. What are the advantages of pre-operative GnRH agonist? It reduces, before subjecting her to the surgery, if I give GnRH, it reduces the size, reduces the cyst size, the endometrioma size. It reduces the hypervascularization and inflammation, so bleeding is less. The reduction in the cyst wall thickness, so peeling may be a bit better, but sometimes the differentiation of the cyst wall from the normal tissue becomes a bit difficult. Reduction of the adhesion. So should I operate or should not I? If I operate, there will be better IVF success rate. It prevents the rupture during egg pickup. It facilitates thus the oocyte retrieval because the endometrioma is not there and it is not obliterating my view. It avoids contamination of the follicular fluid because I have drained all the fluid of the endometrioma. So the occult malignancy also I have detected because sent for histopathology, and all these causes, it prevents the progression of the endometriosis. Why I should not operate? Some advantages of that is cystectomy prior to IVF does not improve pregnancy rate according to some. Surgery and anesthesia risk of the surgery are there. Anesthesia risk of the said surgery is there. Potential risk of reduction of the ovarian reserve, whether I have done diathermy, ablation, laser, coagulation, cystectomy, whatever. Aspiration prior to IVF, there is no increase in pregnancy rate according to some studies. This is one more concise slide where I am telling about the potential benefit of the expectant management and the surgical management. And the lower part I am telling about the potential risk of the expectant management and the surgical management. It is almost the same, putting everything together concise in a slide. So the expectant management, you can avoid the surgery there is no further compromise on the ovarian tissue. And if you do the surgery, there is the rupture does not happen and contamination does not happen, etc., etc. It's almost same slide. Coming to a little bit about the cyst aspiration, though it is not quite familiar to all of us, or we are not happy doing the cyst aspiration, no statistically different response is seen with or without cyst aspiration. So aspiration is a small cyst, especially the small cysts. Better ignore those kind of cysts and don't aspirate them before stimulation. It is not recommended to make an ultrasound guided aspiration also in cases of recurrent endometrioma. Watch me here. It is reserved in cases of recurrent endometrioma. I have nothing else to do for her. At the same time, I don't want this endometrioma troubling me during the pickup. So in those cases, cyst aspiration can be done, which hinders the oocyte retrieval, like the ones more than 4 centimeter. It is also considered in symptomatic elderly women who have low ovarian reserve. These are very small indications for cyst aspiration. Coming to sclerotherapy, sometimes the cyst aspiration is done, it is combined with the sclerotherapy. That is, around all the endometriotic fluid is aspirated with the ovum pickup needle, and that endometriotic cyst is filled with at 99% ethanol, kept for some time, hold that ethanol inside the cyst, and that shrinks and it causes the cyst wall to adhere to each other, and that is how it prevents the endometrioma recurring. Without altering the results of IVF, while a second surgery would be deleterious. As I said, certain cases I don't want to do repeat surgery for her, so this is an option. The disruption of the cyst epithelial lining with the subsequent inflammation and fibrosis that will eventually result in obliteration of the cyst, and that's what I was saying. Clinical pregnancy rate was same in both cystectomy plus or minus sclerotherapy in some clinical trials. What are the precautions to be taken during the ovum pickup in the presence of endometrioma? Endometrioma is there for whatever reason. You've not removed that endometrioma, but you want to do the egg pickup simultaneously. Extra things compared to the woman who is normal, who is the one without endometrioma. I'm supposed to do the following things. The antibiotic prophylaxis, that is a broad spectrum antibiotic, is very much necessary because these ovum pickup can result in the presence of endometrioma. There is an increased chance of ovarian abscess. The second statement, some people do not do this. That's quite fine. 2% betadine vaginal wash, again because the vagina has lot of bacteria and I don't want that to enter the ovary during my egg pickup, especially in the presence of endometrioma, which catches bacteria like anything. So 2% betadine wash, that should be thoroughly followed by the saline wash because we don't want to have even trace of betadine there. Strict asepsis to be maintained during the ovum pickup. Avoid repeatedly exposing the needle. This is very important. Don't take the needle out in, even into the vagina or even outside. Let it be inside the ovarian tissue, just subcapsular as far as possible, so that the tip is not exposed to the outside world. Avoid puncture and aspiration of the endometrioma. So under strict ultrasound guidance, you may have to magnify, put the scope in, showing different views, etc. But ultimately, you're not supposed to puncture and aspirate the endometrioma as far as possible. What are the post-op options before IVF? One is controlled ovarian hyperstimulation and IUI if it is an early stage of endometriosis. This is the surgery is done, but before IVF. She is in that transition phase. What are all the options she has? Second is directly take her IVF because you have seen that stage 3, stage 4 disease is there. She has nothing else left. Post-op adjuvant treatment, that is aromatase inhibitor like letrozole or the GnRH analyze like leuprolide for 3 to 6 months prior to IVF, ET, ICSI, improves the outcome in advanced stages. So give her one shot of GnRH for 1 full month, and then next month you can take her for the stimulation. Test AMH, very much necessary because we should know where she stands. The egg freezing is a question I will explain in my future slides. So coming to GnRH agonists, there are 3 RCTs, randomized controlled trials of 165 patients, some decent volume of patients with 3 to 6 cycles of GnRH agonist before IVF ICSI was done. And that said that GnRH agonist improves the outcome of pregnancy and reduces the miscarriage. It modulates the natural killer cells of the uterus and it normalizes the endometrial aromatase expression. GnRH agonists prior to IVF ICSI treatment for 3 to 6 months showed 4-fold increase. That's quite attractive. 4-fold increase in CPR, that's clinical pregnancy rate, after 3 to 6 months. Letrozole gives better IVF ET result. According to some, clinical pregnancy rate was 61 versus 14%. I'm sorry about the thing there. And the pregnancy rate, that is a live birth rate, was around 50% versus 7%. That's quite good by improving the endometrial receptivity. Unlike clomiphene citrate or even GnRH agonist, the letrozole improves the endometrial receptivity. Now, should I go for the agonist cycle or the antagonist cycle, having diagnosed the endometrioma or endometriosis? I'm subjecting her for IVF, but should I go for agonist or antagonist cycle? Considering the implantation and CPR, COH with both GnRH antagonist and agonist protocols may be equally effective in patients with endometriosis. Ultimately, the result may be same. Clinical pregnancy rate and live birth rate per ET cycle, that is embryo transfer in fresh cycles, in agonist cycle, it was around 25% and 13% in antagonist cycles. But there was no difference observed between these two groups if they are taken for frozen embryo transfer cycles. Many of us nowadays subject the patient for frozen embryo transfer cycles because there are many studies which say that FET cycles are better than fresh cycles. So if it comes to the FET cycles, there is no difference whether it is agonist or the anti cycles. Conclusion. A GnRH agonist protocol appears to result in higher pregnancy and live birth rate after the fresh embryo transfer. There's a fresh embryo transfer in women with endometriosis associated infertility, suggesting, what does it suggest? It says that GnRH antagonist protocol might negatively impact the endometrial receptivity. So is there something the GnRH antagonist cycle that is doing with the endometrial receptivity? So COH for IVF ICSI is equally effective with both GnRH agonist and antagonist in terms of implantation rate, clinical pregnancy rate, but COH with GnRH agonist may be preferred because the availability of more M2 oocytes. This is according to this study in 2007. He says that availability of M2 oocytes was better with the agonist cycle. That subsequently helps us because we have more embryos for freezing. There is no difference in pregnancy rate after IVF treatment between agonist or your anti cycle according to certain studies, as I have mentioned here. According to the Cochrane study, there were 3 randomized control trial and the volume was 165 women in this study. The live birth rate per woman was significantly higher in women who are receiving the GnRH agonist compared to the control group. The CPR per woman was also significantly higher. The study here, the second one is a bit different. It says between the GnRH daily dose or the depot dose. So it says the use of GnRH daily depot dose for pituitary desensitization in IVF cycles increased the number of gonadotrophin ampules. Because of the depot, there was a chronic pituitary desensitization, and because of that, the gonadotrophin ampule requirement is more compared to those women who took daily GnRH agonist shots while we do the ovarian stimulation. This is, I have to skip because this is only about the stimulation protocols, whether it is agonist or anti, different protocols. Studies on ovulation stimulation for IVF do not show, patients should be assured about this fact. Our counseling should include this part, that any aggravation of the symptoms associated with endometriosis lesion does not happen merely for the fact that she is subjected to IVF. There is no acceleration of its progression. There is no recurrence just because we have subjected her to IVF. Recurrence is per se because of the disease nature itself. The fertility preservation, last few slides, maybe about 3 to 4. Fertility preservation in women with endometriosis. Cryopreservation of the oocytes for younger women without a partner is a good practical option because endometriosis is a progressive disease. Whether it is a locally progressive disease or a recurrent disease, it is known for its progression and going to eat away the ovary. The vitrification of the embryos is another good option when she has a partner. Fertility preservation with ovarian tissue cryopreservation may be considered, particularly those at risk of bilateral ovarian injury, such as women with bilateral endometriosis, before chemotherapy, as we subject the patient for the cryopreservation of the ovarian tissue. When we find the bilateral endometrioma, we have to counsel her for this fact, about this fact. Fertility preservation must occur at multiple levels, including careful selection of the surgical candidate. It is not just the cryopreservation or vitrification of the embryos or the oocytes. It should happen right from the beginning, right at the selection of the patient. That is, am I supposed to subject her for surgery? Which is the patient for surgery? If I take her for surgery, what should be the kind of surgery that I am taking her for? So everything should be decided right from the beginning. Avoidance of the repeat surgery is equally important, and meticulous surgical technique, like how you are going to handle the ovary, how much of damage you are going to do on the ovary. Are you going to the ovarian hilum? How much of the amount of the stripping you are going to do? So everything matters. We have to create an awareness among the practitioners also and the public about the cryopreservation, the fertility preservation. Because the fertility preservation is very, very important, and this woman can, if she has preserved her oocytes or the embryos, she can take treatment for endometriosis, concentrate on endometriosis, and get she will be quite assured that her oocytes or embryos are in our cryocans. So coming to the summary, laparoscopy is the gold standard for diagnosis. Whether you're going to operate extensively, not going to operate, just put a scope and come out, whatever, you have to make a diagnosis not only of endometriosis, also about the staging of endometriosis. So laparoscopy is the gold standard, no doubt about that. Respectful handling of the ovaries is very important, no second thought, because we have to preserve the normal ovarian tissue. Endometrioma, if diagnosed, cystectomy is the treatment of choice. May not be possible in certain cases because of bilaterality of the disease or advanced stage of endometrioma. But if given proper situations and chance, endometrioma has to be properly treated in the form of cystectomy. Post-op adjuvant treatment for secondary prevention or the recurrence is also important. Controlled ovarian hyperstimulation with IUI has higher pregnancy rates than sitting at home and waiting and hoping or praying for pregnancy. In stage 3 or 4 disease, that's the advanced stage, operative laparoscopy increases the pregnancy rate because you have done a good surgery, you have removed enough of that venomous endometriotic tissue, and so it is going to yield a better result compared to surgery and then lean back. No surgery and relax. After surgery, immediately take her for the IVF treatment. So expectant management has no role in stage 3 or stage 4 disease. Down regulation for 3 to 6 months prior to ART improves, although overall ART success rate may be low because we have down regulated. So ultimately, I want to conclude with this slide. In the management of endometriosis with infertility, suitable tailor-made treatment. Of course, it has to be tailor-made depending upon each patient is different. So the tailor-made treatment option should be implemented without delay. It is immaterial whether the patient is subjected to medical treatment or surgery, whether you have put her on IUI, you have given her the proper treatment, you have given a tailor-made treatment. Ultimately, your and her goal is getting pregnant. So objectives of the treatment should be fertility restoration. Of course, that is a prior important thing for us, and that too as early as possible. Relief of pain along with fertility restoration, because she is suffering from lot of pain. Underlying disease should be kept under control. I don't want to have recurrence at any cost. Regular monitoring is very necessary because I don't want the endometrioma to grow, adhesions to increase, or her pain to worsen.
So, doctor, we have one question from the audience, which you can see on the chat option. It is that what is the success rate of IVF with patient having severe degree of endometriosis?
Severe degree is, I can say, around not more than 20-25% at the maximum. Because everything is destroyed, and though you have done a restorative surgery or corrective surgery, as I have told, that molecular problem or the underlying tissue pathology is there. Endometriosis affects at each level, as I have told in my slides, right from the follicular genesis till implantation or clinical pregnancy. It affects at every stage, and after she has conceived and she is gets a sigh of relief, she may land up in abortion also. So putting everything together, not at all a happy disease, happy problem for anyone to be with. Endometriosis is enemy of fertility. Thank you so much.